Hello. Hi, this is Jonathan from your YMCA, and I am honored to be your moderator here today for our Be Well session. Today, we're going to be talking about a new plan for mental health calls. First off, I'm honored to have these opportunities to have experts in their field come and share with us about how to live mindfully. And when I think of mindful, I think about us being aware and having the opportunity to choose how we act, how we think, how we feel. And so today we're going to learn more about our community and how we can be aware in our community and support those that might be challenged. Our guest today is Dr. Megan Patrick Thompson. She is the program director over at Exodus Recovery, and they've been involved with the mobile crisis response teams up in North County. Megan, welcome.
Great, thank you for having me.
Thank you for being with us and sharing about this program. Sounds like you have a long history in terms of community behavioral health.
Yeah, from starting from my internship in graduate school up into my career, I've been involved in community mental health, whether working in the crisis houses or in my new venture with the mobile crisis response team.
That's wonderful. So if you could give us kind of the background on how this pilot came about. Obviously, there's been a lot of attention to police and some of the incidences that have occurred in our community and the concern whether they are trained and the best equipped to deal with mental health calls. But let you share just the background, how we got to where we are today.
Yeah, I think it was twofold. I think it was calls from the community wanting to address behavioral health issues in a new and innovative way that's happening in other cities. And San Diego has always been on the cutting edge of behavioral health. And I think there was a recognition that there really was a gap of services and crisis response between our access and crisis line and PERT and law enforcement. So I definitely think that the county took a step back and looked at how can we intervene in crisis in a different way with those who are trained and have those expertise to handle behavioral health crises.
That's great. I'm thinking, just a moment ago, we were having a conversation about what the distinction is with these mobile crisis response teams. And we mentioned PERT, IHOT, homeless outreach team. And so what is the distinction between those professionals that would come and take on various crises?
Yeah, absolutely. So I think it's exactly right? In our system of care, we have a lot of wide range of services, and we're always fine tuning those to see how we can best address behavioral health needs in our community. So we start with PERT. PERT is a clinician that's paired with a law enforcement agency that goes out and is handling emergency situations that really need that law enforcement presence in order to keep the individual safe and the clinician safe in the community. When we look at the homeless outreach teams, those teams are really going out in the community, hitting the pavement and engaging with individuals who are facing homelessness. That they're really trying to connect them with like our housing first model here in San Diego, where we provide housing and then do wraparound services. IHOT is really geared towards individuals who maybe have some poor insight into their mental health issues that comes along with, some of the diagnoses that they serve, like schizophrenia and bipolar disorder. And they're able to engage those individuals longer term and provide them case management and assistance with what the goal of that individual is at the time that they need that service. And so I think that comes to us, like, what is the mobile crisis response team? As we were talking about earlier, crisis is a wide range. And I think one of our goals is to hedge off crisis before it gets to that emergency 911 call. And so that's where the mobile crisis response team comes into play, is we're geared towards those individuals that we want to see within the next 48 hours. Our response time is much quicker than that, but that by industry standard, we want to see in the next 48 hours, assess them, and really get them connected into the behavioral health services.
And so when you were looking at, when the community was really looking at, in conjunction with the county, putting together an alternative response to those incidences, what was the construction? How does this mechanism work? What are the elements that you wanted to make sure that were a part of this?
Yeah, absolutely. I think we wanted to do evidence-based practice. So looking at other models in other cities. I know particularly in San Diego County, we looked at the Harris model, which is out of Houston, Texas, combined with the model in Cahoots, which is out of Eugene, Oregon, and kind of looking at what would be the makeup of these teams. So our team has a licensed a licensed clinician. They have a case manager who is a master's level clinician that also has training, advanced training in behavioral health and intervention. And then we have our community health workers who are peer advocates or peer support specialists. So they either have lived experience with behavioral health issues through themselves or through their families. And so that's what comprises of our team. And really deciding, what's the best way to intervene and go out in the community and provide those services. So one of the neat aspects of our program is we're just not a one-time intervention. So we follow our individuals anywhere from 7 to 30 days post-intervention for this kind of enhanced care coordination. So we're not necessarily case management, but we're making sure that we just didn't hand them resources at the time of referral and say good luck navigating navigating that. Our case managers and our community health workers follow up with those individuals to make sure that they make those appointments and that we identify those barriers that often come with accessing care and help break some of those barriers down.
The model sounds much more comprehensive, and I love hearing about the follow through. I recognize that the population, it could be challenging to track or keep have follow up, and so I'm just wondering how best do you guys go about that?
Yeah, I mean, I think when we look at what are some barriers to continual treatment, I mean, homelessness is one, access, I mean, particularly during COVID time, access to a phone to engage in those. So I think that's where our case managers and our community health workers really do individualized treatment. And so really assessing like, if this person needs an appointment, maybe we need to help them with a bus pass, or we need to go out and connect them ourselves to make sure they get those appointments that they need. A lot of times people don't realize that they can get transportation to medical appointments through their health insurance. And so it's showing and demonstrating to them how they make those phone calls so they can continue that care once we're done working with them.
Megan, does someone need to have certain qualification to be able to be part of this? When you speak of like health
Yeah,
insurance and
so
like
so we're open to all. We don't it's not, if you have private or Medi-Cal or Medicare, in terms of the insurance plan, we're funded by behavioral health services, so we're open to respond to any calls. We just have our criteria that individuals would have to meet to be eligible for our services.
great. And so I'm curious, this particular pilot, was it funded through county behavioral health, or was this a special initiative that came forward?
So this was funded through behavioral health, and this came out of the Board of Supervisors approving additional funds towards this pilot project over the
That's,
summer.
that's wonderful. So tell me, what was the result of the pilot? What were the successes? What were the
Yeah,
learnings?
we are still in the midst of our pilot. So we
Great.
have a slow rollout in January. I think definitely in the months of March and going into April, we are definitely ramping up our partnership amongst our community stakeholders, going out there and doing lots of presentations for various groups, including law enforcement, to let them know what our services are, how you access them. So we are still in our pilot year, and we'll be continuing to fine tune things as we see community demand, and we continue to just fine tune things.
That's great. It sounds like the program must have been successful enough thus far into the pilot year, because it sounds like it's being expanded to other communities.
So right now, I know Behavioral Health Services is working on expanding this program countywide. So that is something they're hoping to get up and rolling towards the end of 2021.
That's great.
Yeah.
So how would somebody, let's say I'm out in the community and I see someone that I recognize is in distress of some sort. It looks like it's a psychological or mental health. How would I access this system
Yeah,
for that
great.
individual?
Yeah, so right now, referrals are screened through the access and crisis line. So when individuals would call, they would let the licensed clinician over on that side know what's going on in the situation. There's a screening that occurs. So, we check for things that would put our team at risk or put the other individual at risk. So we're screening for things like weapons, if somebody is under the influence, if it is a safe situation for us to go to. So we have some various screening items that we go through. And then from there, the referral is sent over to our MCRT team, who then can be dispatched to the call and make that connection.
Great. And then if it is something, I'm just trying, if I see something in the community, how would they have follow-up? I know you recognize best practices to be able to see that person within 48 hours. Obviously, they have to be receptive to that service. And I just wonder, if I'm making a referral, I see someone out at a park, how that works, or that may not be the most appropriate referral.
I think this model works best when the individual is wanting those services, or there's maybe family involvement, and we can provide some services and education to the families to kind of help them navigate a behavioral health crisis. Individuals, like if there's a concern about somebody in the community that maybe is acting in a manner that we would pause and want that person that should be checked on. There's different avenues. There's welfare checks that you can initiate through law enforcement. You can call us, and we can kind of screen to see if that would be a call that would be appropriate for us to go out on based on like the data. Yeah.
Great. So if I was to ask you, what are the kind of mental health calls that you're taking, if I was to get kind of a sense of what that range looks like?
Yeah, absolutely. So right now we're servicing individuals that are over the age of 18. I would say the bulk of our phone calls are coming from either providers or concerned family members. So family that are reaching out to get support and services for their adult children and are having a hard time kind of navigating what services might be needed. And then also providers in the community that are recognizing maybe that their client might need a different level of care than they currently are. So our team is designed to transport people to crisis stabilization units, to walk-in assessment clinics where they can get evaluated by a psychiatrist that day, to our crisis houses. So really our team's designed to go out and make that assessment and then match the appropriate intervention and deliver those services.
That's great. I know you mentioned to me earlier there's different models
Yeah.
of intervention. What would be kind of the range of different models that you're aware of when you guys constructed this one?
Yeah, another popular model is individuals, a licensed clinician being paired up with a paramedic, so emergency medical services. That's a popular one through the In Cahoots program. I'd say the difference between that is they also will respond to medical emergencies. So our team isn't designed to respond to medical emergencies per se. We obviously offshoot those to our EMS, but those models, I think that is an entry point in. So individuals who maybe are struggling with homelessness might reach out for those services because of a physical concern. And then the clinician in that sense can also engage them at that time. We do even have a PERT team here in San Diego that is paired up with emergency medical services. So we do have some different blends of this amongst our county too.
I've always heard, or more recently, I've heard just that our systems for mental health, psychiatric care is overwhelmed. And so, it sounds like we're able to intervene, link them up with resources. Are they able to get that continuing care and engage in that readily, or is there a wait list to be able to have that access?
Yeah, I think it depends on what services that individual is really needing at the time. If it's, they need medications, a lot of times that's a little bit more readily easier to get in pretty quickly. There's some delays in case management sometimes, just because that's a process. It takes time to make sure people meet qualifications, and then also make sure that they're getting the right level of case management. You don't want to shoot someone too low or too high. So I think, it is complex trying to match people with, just even like you spoke about, is there's all these different programs, and we're trying to match people up right with the programs that they do need. Yeah. So.
And it sounds like this intervention is for up to 30 days.
Yeah, so there's a potential for us to follow them anywhere from 7 to 30 days. It's kind of really based on their needs. So if we do have an individual that's really having that hard time getting connected to the services that they need, we're going to follow them longer. I would say the most of our clients are followed in, 7 to 10 days after the interaction, that we're able to kind of get them in the services that they need at that point.
Great. So Megan, based on your experience in running this program, what would be like next steps, or what would be recommendations that you see that we're not addressing in this current model that you think would help improve the delivery?
Yeah. I think that we've done some great work with our partners at the Access and Crisis Line. I think there's lots of room to go out, just like in these avenues, and get the word out that our service is actually here and it's available, and what we do. I know there's lots of talks at the county level of how do we interface these programs in with law enforcement, so to divert some of the calls that would be more appropriate for our services. So I think those are those important next steps that are already in the works, that from my end on the pilot program we've been recommending.
That's great.
Yeah.
Anything that we can do as community stakeholders to support this program? Obviously, in spreading the word is helpful. If we know of family members or providers that would benefit in knowing this information and being able to make a referral or get the services, but anything else that we can do as community?
Yeah, I think that this program was in part brought upon because of the community, right? Our community saw a need and really advocated for it. There's been a lot of advocacy for this program. And so I think that that's just it, is when we see these needs in our community, that we make sure that our voice is at the table to make important changes. So even as we're going in this pilot program, is just really trying to give us feedback, or ask questions, and so we can kind of keep honing this program to continue its success.
That's wonderful. Well, I appreciate your time and sharing about this program initiative, and I'm excited to hear that it's going to be spreading to other communities. I appreciate the work that you've done. Anything else that would be helpful for us to know, or anything else you want to share about those?
Oh, there's so many. Well, I just think, once again, if you have somebody in mind, or you would like more information, to feel free to reach out to us. I know our website just went out in the chat box, so just making sure we're open to presentations, open to coming out and talking to individuals about how to access our services, and who we do and do not serve. So we're very open to getting the word out about our services.
That's fantastic. Well, Megan, thank you again for the work that you're doing. Thanks for being with us today and sharing about this program. I wish you continued success and impact moving forward. And again, thank you very much.
Yeah, thank you.
Everyone else, please be well, and we'll see you again next week. Thank you very much.